everyone. My name is MJ. We haven't met. I'm a PGY3. I'm going to be discussing compartment syndrome and the indications for fasciotomy of the limb. Okay, great. So first, acknowledgements, procedure team. Shout out to you guys. Thanks. So I'm going to first define acute compartment syndrome, talk about some causes, how we measure compartment pressures, and intervention. So what is acute compartment syndrome? So simply put, it results from increased pressure within kind of a confined space, typically a myofascial compartment, and that increases to the point where your nervous and your function of your muscles and your nerves within that space decreases. It is an orthopedic surgical emergency. So as ER physicians, we should be able to understand it, identify it in a timely manner, and expedite definitive treatment. It typically occurs in younger individuals because of increased muscle mass, and it most often occurs in the forearm or the lower leg. 58% of ED, acute compartment syndromes, are due to trauma in those two areas. And that's pretty much it. You can get compartment syndrome in any kind of space that's confined by fascia. So that could be your lumbar, paraspinal muscles. It could be your gluteal compartments, your hand, your abdomen, and so on and so forth. But since this is an ortho-themed week, I'm going to concentrate on the extremity. So like I said, the major cause is trauma, but there are other non-traumatic causes that we need to be familiar with as well. So you can have muscle ischemia from necrosis from like a contusion, especially from patients who are on anticoagulation, swelling from a fracture or volume overload, edema, or a thrombus that transverses the compartment. So like long bone fractures, crush injuries are the more common causes, but we can also have like circumferential burns, seizures, eclampsia, and like rhabdo can also cause it. Fluid overload, like I said, envenomation, exercise. So you can actually have like chronic exertional compartment syndrome and like your long distance runners and your athletes. But I'm going to talk about acute here. Blast injuries or reperfusion after ischemia and a bunch of others. External causes like casts that are too tight or splints that are improperly placed. But we also must be careful with iatrogenic causes, such as extravasation from an IO line or an IV line that can be caused by a leak or improper placement. Another thing to keep in mind, the main key to making this diagnosis is assessing and reassessing your patient. So particularly those SICU patients or ortho patients that are reporting in the main or in CCT, whose pain is not kind of controlled despite multiple doses of opioids or strong analgesics. So what exactly do I mean when I say compartment pressures? So tissue perfusion is dependent on your arterial pressure, mostly your diastolic, and your venous capillary pressure. So lack of perfusion occurs when your tissue pressure begins to exceed your perfusion pressure. So as your compartment pressure increases, your tissue perfusion decreases. And the hypoxia results in tissue necrosis and damage after extended periods of time where the pressure exceeds like 20 to 30 milligrams of mercury. Normal is less than 10. Okay, so as early as within 2 hours of your insult, so like your fracture, your trauma, you can develop decreased sensation. Neuropraxia or neuronal paralysis can occur within 4 hours, and irreversible damage can occur within 8. And then between 8 to 12 hours, you can start seeing irreversible damage of the muscle as well. Okay, so if you're like me in medical school, you memorized your 5 or 6 Ps to identify concerning signs and symptoms that would point you to this diagnosis. So can anyone give me 1 or 2 of them? I talked about pain already. Thanks, shout out to Lisa. Okay, so the earliest indicator is pain with passive movement, pain out of proportion to exam, which is a result of the increased pressure. It can develop within the first few hours or can be delayed as well. Anything else you said? Pallor, okay, anyone else? Pulselessness? Yep, okay, and what is that? Okay, yep, so a temperature differential between the extremities when you compare them. Anyone else? So we have pallor, pulselessness, paresthesias, paralysis, okay? 5 or 6, depending on who you talk to. So yeah, so pain, poikilothermia, which nobody ever says, paresthesias, are kind of more earlier signs, and then your late signs are pallor, paralysis, and pulselessness. Obviously, you should not wait until all these signs are present before intervening or conducting your compartment measures, because you're like, oh, they're already pulseless and have paralysis. Maybe it's time you should call ortho. No. Also, things to keep in mind, your patient might be obtunded or unreliable or generally just like not awake or alert. And they might not be able to tell you if they're having sensory deficits. If they can withdraw from pain, you can try to stretch kind of like the distal structures, like their toes and their fingers, to see if they wince. But predominantly, you'll have to depend on like other signs to help guide your clinical judgment, clinical decision making. And then other considerations to have regional nerve blocks, like when we have that long fracture and we just block them, it can result in delayed diagnosis or because you are obscuring some of their symptoms, especially when you use something like bupivacaine that can last for 6 to 8 hours. Okay, so although you can note firmness and fullness of the extremity, it's not really reliable for your diagnosis. So manual palpation, the sensitivity is like 24%, and specificity is also really low. Positive predictive value is like 19% too. So it's not sensitive or specific enough, but you can try it. So that brings us to measurement. So I'm going to review some of the anatomy of the lower leg, since everyone loves anatomy so much. So you have 4 compartments. You have your anterior compartment, your lateral compartment, your deep posterior, and your superficial posterior. Your anterior compartment is comprised of your extensors that dorsiflex your foot. You'll also have your deep peroneal nerve that travels through this compartment to innervate the extensors, and you get sensory from that web space in between the first and second digit. Your anterior tibial artery goes through this compartment as well. Your deep posterior compartment contains your tibial nerve, and that supplies the muscles of the compartment as well, and the sole of the foot. Also contains your posterior tibial artery and your peroneal artery. I just highlight those 2 because they have the highest incidence of compartment syndrome. Also, they have a lot of major nerves and arteries that run through those compartments, so it's a lot easier to identify it a little bit earlier. Okay, and in the forearm, you have 2 compartments, so your volar or your anterior and your dorsal or posterior. So your volar compartment has all of your forearm and hand flexors, your median nerve, your ulnar artery, and radial artery, and your common interosseous artery. And your dorsal compartment has your digital and wrist extensors, and your posterior interosseous artery and nerve. There's no real major arteries or nerves that go through your mobile wad. It's kind of just like your brachioradialis muscles and a couple of other muscles. And your dorsal compartment is more high risk than your volar, which is important for like supracondylar fractures in pediatrics and distal radius fractures. Okay, so the precise intracompartmental pressure that should mandate surgical decompression is kind of like unclear and inconclusive. And compartment syndrome is a clinical diagnosis, but if you choose to measure the compartments, which most people would, there's no real definition. But less than 30 millimeters of mercury, they don't really need any intervention. Greater than 45, they probably need immediate decompression. And then between 30 and 45, there's kind of like this gray area where they might need it or might not. So it's not the best to use just that one measurement, which brings me to the next one, which is an alternative approach, is to measure the difference between the diastolic pressure and the compartment pressure, which gives you your delta pressure. less than 30 is suggestive of compartment syndrome. And they came up with this threshold based on like prospective studies and observational studies, and they looked mostly at the tibia and fractures, like traumatic fractures of the tibia. One observational study looked at continuous pressure monitoring over like 6 hours. These patients had compartment pressures that were above 30 for longer than 6 hours, but none of them developed acute compartment syndrome. And they went back and looked, and all of them had compartment delta pressures that were above 30. And then there was another observational study of a much smaller sample size that had similar results as well. So it's not perfect, but it's pretty good. Okay, so the next one, I'm gonna just show a video real quick. I don't love the video, and I have some critiques at the end, but it is MRAP, and it's just
to get that all
easier.
Sterile and anesthetized. Now we're gonna do this in 3 parts. First, we are going to show you how to set up and calibrate and use the Stryker intracompartmental pressure monitor system. Then we're going to do a little bit of a review of the anatomic compartments and where to insert the needle for each compartment. And finally, we're just going to top it off with a little bit of rainbow sprinkles and do some pathophysiology right there at the end. All right, so there's one thing you need to remember before you start, and that's the number 30. The number's 30. What's the number?
30.
That's right, and that's because if the pressure in any compartment is above 30,
We also talked about this.
Also, if the delta pressure, which is the difference between the diastolic blood pressure and the compartment pressure, if the difference between those is less than 30, also bad. Now, let's get started. To set it up, you have your sterile components, a 3 cc sterile saline syringe. You have the chamber, and you're going to connect them thusly. Now you're going to connect the needle to the other side, and the needle has a side port for measuring the pressures. And we're going to clear out the air in the chamber by injecting the saline into the chamber. No air bubbles are allowed, and you do this holding it at 45 degrees. And you may have to give it a little bit of an aggressive flick, like a subungual hematoma kind of flick. There, easy peasy, looks good. Now we're gonna load this into our pressure monitor. So we'll open this chamber up, and it should snap right in place. The drawer should close nice and easily. If it doesn't, then you need to readjust the angle of the phalange of your syringe. Let's turn it on, and to zero it, you're gonna hold it at the angle that you're gonna use to insert it into the patient, and you're gonna hit the button conveniently labeled 0, and you should get 0 on the screen. Now we're ready to check our compartment pressure. So put on a fresh sterile glove, repalpate your landmarks, and go ahead and insert it into the compartment. You might feel a pop as you go through the fascia. Inject about 0.3 ml of saline, and now it should read your compartment pressure. You know you're in the right place because if you squeeze that compartment, you'll get a rise in the pressure. The pressure is over 30, so this is consistent with compartment syndrome. And I think he's gonna need a fasciotomy. I'm so.
Okay, yeah, so I cut it short. So the Stryker, so the Stryker compartment monitor is what we use to measure compartment pressures. And I know there's definitely one in SICU, or the ortho resident always like brings it if you need it. I don't know if we have one in the ED or available. Do you know, Kathy?
I know.
Yeah. So a couple of things, make sure you sterilize the whole area that you're going to use and not just like that one spot, because you're going to be measuring multiple compartments. That was my first issue. Second, warn the patient before you inject the lidocaine, don't just stab them. And then we talked about the like 30 threshold already. And remember to inject 0.3 cc's and not 3 cc's because you don't want to inject more into a compartment that already has like a lot of pressure. So that's important. And then another thing to consider before you say, oh yeah, it's over 30, let's do a fasciotomy. lots of things. You have to make sure that the patient is hemodynamically stable. Like if it's a femur and they have like a femur fracture in that compartment, has swelling, like a hematoma or something else, just make sure that they're not like hypotensive or anything else before you start just stabbing. And then as always, like you would never do this by yourself. If you're measuring the compartments and you have a high suspicion, you should have already gotten ortho or surgery on board. And then the other thing that I like is that if you don't have this striker system, you can create one. You can jerry rig one because we're county and, and we like to jerry rig things. But all you really need is a line kit, arterial line transducer. So you can use that too. Or any kind of bedside monitor that's capable of like transducing pressures. So you take the A-line kit, get the tubing all set up with the pressure bag. You attach it to a 3-way stopcock, and then you take a 10 cc syringe with saline and attach it to one of the ends of the stopcock. And then you flush the system, obviously. You zero the monitor. You attach a sterile 20 gauge needle, because again, this is kind of sterile as well. Not kind of sterile, it is sterile. And you can inject 0.1 to 0.3 cc's through before you check the measurement. Okay, and then you record the reading. Any questions on that? No? Okay, cool. All right, so your sites that you want to go into, I'm going to go over all of the landmarks, but you should kind of perform this within 5 centimeters of a fracture site, and then also just be wary of any like cellulitis. You don't want to introduce any bacteria. Ideally, that's not the location you should be going into. But for your anterior compartment, you want to do like, oh, I forgot you can't see that. About like 1/3 of the way down the tibia. You can do 1 centimeter lateral to the anterior border of the tibia. And as always, you go in with a perpendicular needle. For the lateral compartment, you can go just anterior to the posterior border of the fibula. For the deep posterior compartment, you want to go kind of just posterior to the medial border of the tibia. And then for the superficial posterior compartment, honestly, with this one, it encapsulates kind of the whole calf. So you can kind of just go in the middle of the calf, but they say like 5 centimeters off the midline. So just to go back with the anterior compartment, when you're measuring, she mentioned that while you have the pressure monitor in there, you can increase the pressure if you flex the foot, which she's doing there. And then for lateral compartment, you want to invert the foot, again, because we went over the anatomy muscles when it's there. Deep posterior, you want to do toe extension, and that'll increase your pressure. And then I'll help you know that you're in the right compartment. And with superficial posterior, you want to dorsiflex. Okay.
You're just doing that to identify your.
Yeah. Mm-hmm. It's kind of like with ultrasound when you augment with a calf, and you're like, oh, okay, it's kind of like a second check measure. And then for the forearm, for your volar compartment, you can go about 1/3 of the way down the forearm as well. You should have your patient in kind of the arm curl position again because of the flexor muscles. And in the video, they show that they place the patient pinky to thumb, which is another method that you can do as well to increase the pressure. And you want to go about 1 to 2 centimeters medial to posterior aspect of the ulna. And when you're inserting, you should be going about 1 to 2 centimeters deep. And for dorsal, the middle between the ulna and the radius. And then the pressure will rise with wrist extension, like what she's doing there. Okay, so that brings me to this. So complications, you can develop necrosis and contracture of the affected limb if you leave the acute compartment syndrome untreated. So the first step in any of this is to make sure you perform and document a thorough neuro and vascular examination of the affected affected extremity in order to compare it later. Second, if there's a cast that's causing the symptoms, take the cast off. That might just relieve the pressure. And then of course, The treatment is emergent fasciotomy. The goal is to relieve the pressure and to reestablish blood flow if it's compromised. So ortho and surgery should be on board, and they usually perform it bedside. I'm not going to go into it too much, but you want to make sure that you definitely mark the site. It's definitely a sterile procedure. You want to make sure that they have systemic analgesia and local before you start too. So for the lower leg, the aim is for the incision to be located over the anterior intermuscular septum, and it's more preferred than the posterior medial incision. And then the thing that you need to be careful of is to not transect the superficial peroneal nerve. And then likewise for the forearm, decompression of the volar compartment is usually preferred to the dorsal, even though dorsal is usually more compromised. Because when you decompress the volar compartment, apparently it helps decompress the other surrounding compartments a little bit more. But yeah, and then the thing to watch out for here is to not go so lateral that you might hit the radial pulse. Obviously be careful of any arteries or nerves that run through that compartment as well. You want to ensure that the incision is deep enough because you'll get edema and hyperemia after the decompressive fasciotomy, which can lead to increased compartment pressures after the procedure. So you want to make sure that it's deep enough because other compartments can become involved in the ones that you did not decompress after. And then it can be left open after with a loose dressing and a splint. And you want to give prophylactic antibiotics, especially if there's like a traumatic fracture or something. And typically people have great outcomes because with early intervention, most of the morbidity that's associated with this occurs early. So if you can intervene early, then the chances of them having any deficits are low. Preguntas? Okay.